and I'm also an ILCO guideline member. I've done primary research for which I've received material and some hardware, but that's got no relevance to my current presentation. So we are in this strange world where in 2020 everything got a bit halted. As you know, the resuscitation guidelines usually get an update every 5 years. I'm showing you the European resuscitation guidelines, first leading author Jonathan Wiley, and we were expecting exactly on the date of the 15th of October 2020 to present the world with the updated ERC guidelines for all age groups, including, of course, neonatal resuscitation. As you can clearly see by the flow diagram on the right-hand side of the screen, it looks a little bit different than the NRP or the American Heart Association algorithm, but it is in essence very similar. There's subtle differences, some of which I will allude to in my talk, but to not confuse the neonatal community worldwide, we are doing enormous amounts to have these guidelines in parallel with similar guidance, which comes from the same evidence. And Jonathan Wiley and Myra Wyckoff are particularly to be commended in driving this unification of the transatlantic guideline. So we, of course, are in this funny year where we could not present in October 2020 because the focus was on getting COVID sorted in Europe, and we've tried and we've failed as other places in the world. So the guidelines will be now presented in exactly a month from now at the ERC Guidelines Conference. Until we present the NLS Guidance 2021, the 2015 edition holds the fort and should be please followed in those countries who do dare follow the European resuscitation guidelines. I very warmly invite all of you to join us at the Resus meeting, which is called the Guidelines Conference, and will take place in the lovely Belgium town of Ghent, and it is, of course, Antwerp, and is, of course, a fully virtual meeting where you can meet all people around the world with an interest in resuscitation, and the neonatal resuscitation community is strongly represented there. This is to show that the International Liaison Committee on Resuscitation has members which are also in the ERC. I mentioned to the lead to Myra Wyckoff, Professor Wyckoff from Texas in the United States, and down on the left here in the pink shirt is Jonathan Wiley, and it's thanks to these amazing peoples and leader resuscitation that we now have almost unanimous guidances in our different guidelines. This seems to be a faulty slide, I'm sorry. So today I want to present what's new in neonatal resuscitation 2021, and I'll go through it topic by topic. Appreciatively, my talk is going to be much drier than Satyan's, who I really admire for his beautiful graphics, and I know it's his talent to bring knowledge to people through illustration, and I greatly admire this graphical representation of very complex physiology because it sticks perfectly well. My slides this time are much more text-based, and I'll go through the different aspects one by one. So when we resuscitate baby, it is to be highlighted that temperature management is key. We've learned from the observational studies from Laptok and others that 1 degree of temperature loss in body temperature during neonatal stabilization and resuscitation can be associated with an up to 30% increase in morbidity and also in mortality. So keeping babies warm should be one of our first focuses when we approach a newborn baby. Stimulation is also something that we always have written in the guidelines, but with recent audits and also systematic review, we found that stimulation is something that we're pretty bad at doing. So keeping babies warm should be our first focus, and stimulating babies when they're born another. We are aware that when we stimulate babies, we increase their respiratory drive, and therefore we increase their oxygen saturation. We know that keeping term and also preterm infant is important, and the use of skin wraps is now advised up to in preterm infants of 32 weeks or lower. And please put them in the bags undried, just the wet, slippery old baby into a food-grade plastic wrap or a specially purchased plastic device, and then put them under radiant warmer heat to keep these babies nice and dry. The next step to, of course, take into consideration is what is normothermia. And normothermia for a newborn baby, whether preterm or term, relates to temperatures of 36.5 to 37.5 degrees. Do stimulate, because stimulate in babies is a good thing, and it stimulates breathing effort. We had a phenomenal morning, and I was privileged to give a seminar, which would have probably been your evening, the very morning hours in Europe, and we talked about delayed cord clamping. The evidence for delayed cord clamping is very strong, and I won't go into this in detail because it has already been discussed in the changes from 2010 to 2015, and is written in stone in 2015 guidelines to delay cord clamping for 60 seconds wherever possible. We talked about why and how to best facilitate delayed cord clamping in the delivery suite, pictures shown here, or of course in a setting of cesarean sections in the operation theatre. My take on this is it's a team effort. We need to take the obstetrician, the midwifery team, and the neonatology team side by side and act as one to make a distinct plan on to perform delayed cord clamping. And in these two images from a twin delivery of 24-week gestation preterm infants, you can see the obstetric team and the neonatal team in the obstetric field facilitating thermal care by putting the baby in a plastic bag. The neonatal team attaches the saturation probe on the right hand of the baby, and it's the neonatal team that denotes the timing of cord clamping. So the baby doctors are the one who assess the newborn infant, and if they're happy with the newborn infant's condition, they give the shout out on when to clamp the cord. The 2021 guidelines will stick to the recommendation that at least 60 seconds should be are recommended and should be performed. There is emerging evidence that it is advantageous to perform what we've called physiological-based cord clamping, and Satyan and Peter have quoted their own research, which in part also comes out of Melbourne, Australia, and Monash's Ritchie Center, the physiologists group, who have pointed out that waiting until the baby takes its first breaths has a very positive effect on lung aeration, and together with lung aeration also the cardiovascular transition. And Satyan very elegantly illustrated how increasing cardiac preload increases circulatory stability and reduces swings in cerebral blood pressure, for instance. Conversely to our maybe beliefs, it's not really, it doesn't really matter whether we hold a baby above or below the level of the placenta. Studies from 10 years back in Argentina have established very well that gravity does not play a significant role in facilitating placental transfusion. This mannequin photograph from a simulation study just illustrates how thermal care can be practiced by the bedside, and this is exactly what we saw in the preceding photograph. You see an infant, this is a model of a preterm infant, in a food-grade plastic bag, sparing mouth and nose, whilst the umbilical cord is still attached to the placenta and the baby is just newborn. We also see application of some form of hat, whether it's woolen or plastic, to decrease thermal heat loss or via the head. Once the baby is in such a bag, and preferably you've got access to a mobile radiant heater, the baby's temperature can be maintained very sufficiently for 1 to 2 minutes for sure. We move on to the next topic, and that is what to do with babies that are born through significant meconium. It's been already mentioned in the preceding talks that we no longer routinely intubate these babies to suction their trachea. Since the 2015 guidelines, we have 4 trials which have investigated this in a retrospective or in a prospective manner. And all these trials have come up with slightly varying recommendation. We note here that the esteemed previous speaker, Satyan, is one of the co-authors of a very large cohort study investigating the practice change. And we've also looked at a large cohort in the UK. In essence, we found that these different studies had slightly heterogeneous quality for their retrospective or prospective nature. And we are quite happy to summarize that the practice change from routine intubation to a more permissive approach has not increased the incidence of meconium aspiration or a significant increase in sick babies. But by being less invasive and more permissive, we've managed to have a significant reduction in NICU admission for babies born through significant meconium-stained liquor. And I think that's a huge benefit for babies and for families. The recommendations, which will come out in March, therefore say that the routine visualization of the cords and suction below the cords is not recommended, and babies should be supported, if compromised, with CPAP from the word go, and we should not waste time by suctioning the oropharynx or even visualizing the cords and suctioning below them. How about the big topic of airway oxygen, initial inflation, and assisted ventilation? Peter Davis elegantly showed that airway management is key, and good airway skills with a mask and a non-invasive approach are the cornerstones of newborn resuscitation. This image shows an operator using a T-piece device, trying to do proper jaw thrust and neutral position mask hold technique. And that is what the most recent updates will continue to advocate. And we will continue to advocate that the majority of babies who transition suboptimally will come around with sufficient support of airway and breathing and will not require any higher-end resuscitation. Bringing again Peter's point home, it's important to have good mask technique, to train yourself by the use of a respiratory function monitor, or to even use higher levels of technology during resuscitation, like a respiratory function monitor, to educate you on your mask leak and your applied pressures and tidal volumes. But the clinical picture is the most important. If you're an experienced resuscitator and you work with an experienced team, feedback from the device and from your team will tell you whether you have chest rise or not, and simple corrective measures are usually the easiest and most helpful. We continue to advocate CPAP as the primary mode of non-invasive respiratory support for breathing infant, for any form of infants, and the pressures are 5 to 6 centimeters of water. We appreciate that there is a trend to also using higher pressures of CPAP. However, we base our recommendation on the best available evidence, which has investigated 5 to 6 centimeters of water. The European Resuscitation Council and NLS guidance includes the use of inflation breaths from birth. This is different from the NRP program, who does not support the inflation breaths. We thought long and hard about whether in 2021 we will continue to advocate 5 inflation breaths, which are different from sustained inflations. These are short mask inflations of 2 to 3 seconds. And we decided that in the absence of evidence of harm and in absence of any other studies suggesting that we should not advocate inflation breaths, the NLS algorithm has included, once again, the mask inflations for non-breathing infants. Satyan has done an amazing job in illustrating the present and the prospective studies investigating the oxygen concentrations from birth. ILCOR has commissioned 2 instructive systematic reviews and meta-analysis on the topic of which oxygen concentration to use in preterm infants and in term-born infants. The group around Michelle Walsh et al. Has done an amazing amount of work of all existing randomized controlled trials addressing this question. And to summarize, the verdict is still out on the best FiO2 for preterm infants. However, it is acknowledged, as illustrated by Satyan so elegantly, that most infants will require an oxygen concentration higher than room air, or 21%. The phenomenal work by Ola Saugstad and Max Vento is also acknowledged, and it's even getting stronger with each study that is performed in the same manner in term-born infants, where it's very clear that room air should be advocated as the starting oxygen concentration and not higher concentration of oxygen. And room air has a 27% relative reduction in short-term mortality of these infants, and that should be advocated for any infants greater than or equal to 35 weeks of gestation. So in the upcoming update on the NLS algorithm, we advocate room air for infants greater than 28 weeks of gestation. And for those of smaller gestational ages, just as Satyan said for the NRP, we advocate 30% of oxygen. Aryan Tapas is the senior author on the DECA paper, which Satyan has illustrated and talked about, where the 44 infants were randomized to either high or low oxygen or really high oxygen. And these preterm infants appeared to do better in the high oxygen group and transition smoother with reaching the oxygen targets faster. However, we do appreciate that this is a small single randomized control trial, and we will need for further evidence from large randomized control trials and meta-analysis before we change our guidance. Individual practice may differ in view of these, but the guidelines will say if you're born at more than 28 weeks of gestation, start with 30% FiO2. The assessment remains the same, and the most sensitive response to your FiO2 and to your airway maneuvers is your increase in heart rate, and that should be the primary focus. Again, we advocate the manual inflations, but not sustained inflations in babies who are not breathing. How about moving from mask ventilation to more invasive or forms of respiratory support devices? Clearly, Peter has illustrated the growing lack of expertise in endotracheal intubation, and also the lack in performance with non-invasive respiratory support. Peter and myself, we led a group of investigators who addressed the ever-discussed topic of whether, when doing non-invasive respiratory support, should we be using the newer devices called TPs resuscitators, which are constant flow pressure limited devices, or is the difference negligible and we should still resort to giving positive pressure ventilation by the self-inflating bags? ILCOR gave us the mandate to do a short systematic review, which is a scoping review, where with a very, very clearly defined expert literature search, we have scanned the existing literature on whether which of the two most commonly used devices have been investigated in higher quality, large-scale clinical trials. We identified, since publication dates of 2010, 4 new studies which were not in the 2015 Resuscitation Guideline, involving more than 2,800 infants around the world. These were 3 randomized controlled trials and 1 large-scale observational study. Meta-analysis of these studies, sadly not privy to share the full systematic review led by the amazing Daniela Trevisanuto, which is just undergoing publication, which has shown that by using a T-piece, particularly in the more immature infants, there are marginal effects and benefits towards survival compared to the T-piece resuscitator. Moving on to more invasive forms of respiratory support, intubation is a difficult skill. Laryngeal mask airways have been suggested in many editions of the NRP and NLS resuscitation guidelines and manuals. However, the limitations are clearly lack of studies of a uniform laryngeal mask, and you see here several different devices which are currently commercially available. And the second limitation is the size of the laryngeal mask, which, according to manufacturer's recommendation, this far does not go down any further than 1,200 grams. So there are currently no devices or laryngeal mask airways for infants smaller, with lesser weight than 1,200 grams. I'll summarize this in a second. Satyan also gave a brilliant illustration on chest compressions, the effect on circulation, and in conjunction with drugs like adrenaline. We continue to advocate to perform chest compression in compromised newborn infants where the heart rate falls below 60 beats per minute. And as alluded to also in the as part of the NRP algorithm, the NLS will also advise to increase the FiO2 to 1.0 or 100% oxygen. If circumstances permit, we urge to consider to secure the airway. However, we acknowledge that intubation may not always be the skill of the first-line responder. So we urge people to train up in the use of laryngeal mask airways to have at least a secure airway, which is second best to endotracheal intubation. The coordination of inflations and compression has not changed, and for newborn resuscitation, we continue to advocate 3 breaths to 3 With regards to vascular access, we have done some meta-analysis and review, and we conclude though that whilst there are newer devices and there's increased use of intraosseous needle, the umbilical vein should still be favored as the primary route of access in term and preterm infants. Wherever possible and where providers are comfortable, intraosseous access should be considered as an alternative mode for administration of drugs and fluid in the context of neonatal resuscitation. We also heard very elegantly on the background of giving drugs like adrenaline. Here in the NLS guidelines, like in the NRP, we suggest a range for epinephrine or adrenaline, here to be dosage portrayed by 10 to 30 micrograms per kilogram for the intravenous route, or at higher concentrations, illustrated also by Satyan, when given via the endotracheal route. We advise to be mindful of dropping blood glucose levels and to consider glucose bole in the context of resuscitation. And we are mindful that anemic or exsanguinated babies might benefit from careful administration of crystalloid fluid boluses, or if available, blood products like packed red cells. Lastly, we have spent a lot of thought, and we've involved a medical ethicist, colleague Dominic Wilkinson, in expanding our recommendations on the prognosis of immediate resuscitative efforts in the delivery room and in the context of neonatal resuscitation. We've expanded the time frame after which provided a period of time of expert intense resuscitation was provided, and there's no proof of any improvement in outcome, i.e. no increase in heart rate or no increase in spontaneous activity of the child. Then after 10 to 20 minutes, it may be considered to discuss amongst the team and in conjunction with the family to redirect the treatment goal from resuscitation to palliation and to stop resuscitative efforts. This brings me to my concluding slides. The top 5 messages from the NLS Update 2021 will be: 1. Delay cord clamping wherever possible to optimize the infant's condition, and it's especially important in preterm infants. 2. To be mindful of administering effective thermal care, drying, wrapping where possible, stimulating always, and when a preterm infant is being resuscitated, immediately slip the baby into a food-grade plastic bag without drying, but continue to stimulate. The assessment of breathing and heart rate is a clinical skill, and an increase in heart rate is an important measure of your resuscitative efforts in conjunction, and assess accordingly. The simplest steps often lead to the greatest success. So, as illustrated by Peter and also Satyan, by simple airway maneuvers and maybe moving from a single provider to a dual provider technique, can we achieve airway inflation and stabilization in most babies. Chest compressions are extremely rarely necessary once steps 1 to 4 are expertly performed, and are usually hopefully transient, and the effect of which should be evaluated every 30 seconds. My personal conclusion on the great efforts from both the ILCO team and the European Resuscitation Council teams are that in the guidelines review generation process, which we've stopped reviewing literature in the fall of 2020, includes all the latest evidence up to then of original research and systematic reviews. It is a great credit to Myra Wyckoff and colleagues to also include the enhanced understanding which we have of neonatal to fetal to neonatal transition through animal study and physiology studies. This all has helped us to sharpen up the 2021 recommendation on newborn resuscitation. However, it does not lead to complacency. We need more and more research in this very important area, and we need to learn how to better define the best treatment policies for infants of all different gestational ages. So there's much more work ahead of us. I thank you very much for your attention, and like my previous speakers, I'm extremely looking forward to your questions. Thank you.
Thank you, Charles.